19, I was playing volleyball. I didn't really care. I just knew I hurt and I
What?
couldn't play anymore.
Okay, what after you? Okay, you are on the floor. You have back pain. You have leg problem and so
Yep.
on. What happened then?
Oh, I laid there, then stood right back up and continued to kind of tough it out until the next morning.
Wow.
Typical athlete.
The next morning, I wasn't getting out of bed.
Stoic.
That's all athletes
How did you know?
except for basketball.
How did you know the bone is broken?
I ended up going to one of our, I would say, I think it was a physician turned chiropractic office that our school is associated with, and they did x-rays.
So you got the X-ray, and then you found out the bone was broken, and everybody thinks broken bone. You're going to get surgery.
Yep.
But did you?
I did not.
You see that there? That's exactly the point I'm trying to make. And as well, I'm sure you have had. You said you have back pain.
Actually, sometimes when I'm about to start menstruating, I have really bad back
Oh.
pain in my lower back.
Mhm.
Well, and I have back pain all the time, but sometimes it flares up and so on. Obviously, I haven't had surgery either. So here you have 3 people who have history of back pain or spine problem that did not require surgery. So even though surgeries are very common, the back problem are even more common.
Mhm.
And yeah, Alyssa, you have been with us now for almost 2.5, 3 years.
Yeah.
Okay, well, so you have
Been
a
a
good
while.
idea. You have a good idea. All the other thing we do beside the surgery. Like, let's start with Amanda. When you have back pain, how do you treat your back pain?
Well, I just know that it's going to be temporary because, like I said, I get it when I'm menstruating, but I just do some extra yoga stretches.
Stretches and so on, and that's come very close to one of the things we do,
Mhm.
which is PT. Yeah.
Yep.
So tell us, I come as a patient to you with a back pain. I have back pain. I have some leg pain, maybe a little numbness and so on. What's the first thing you tell me?
Who almost always the good first step is going in to see a physical therapist. One, just to get that initial workup to see, hey, are we dealing with the muscular side of things versus an actual mechanical spine issue?
Obviously, you will rule out instability. Like, you
Right.
make sure that I'm not, losing bladder bowel function. I'm not, like rapidly losing, motor function. We made that Inspired Spine
Mhm.
multidimensional protocol. On top, on the red, acute progressive neurological
Mhm.
symptoms. Bladder bowel function is the first. Second is acute and progressive neurological function. You rule that out. But once you rule that out, practically everybody should get first non-surgical treatment, and physical therapy is the main part of that. And if you are like Amanda and you sort of build your physical therapy around your routine life,
Mhm.
Yeah.
like you go, you're telling me you always go every day, you go walking, you every day you do some exercises, and that's a healthy way just to reduce that chance. Because if you're a human, you'll have a spine and you will have spine problem. Like 99% of the time, you will have spine problem. To reduce the chance that it progress to a bad place is you just have a healthy lifestyle, and you have
Try and
different
stay
activity, different activity, different position, and you put your all, not only spine but all your joint to a good amount of maximum range of motion, stretches,
Mhm.
Pilates, yoga. And it seems that all cultures have come back to that in one way or another. Like in Eastern culture, you have yoga, and then we have the Pilates, and then we encourage the children to go and play,
And
and
we also have Tai Chi.
Tai Chi in the Far East, exactly. So it seems that in all cultures, we sort of figured out having a moderately active lifestyle is a good thing. You talked about sport injury.
Mhm.
They're not that rare.
No,
Okay.
I would imagine about
Yeah.
every single sport athlete I
Yeah.
know has had some sort of injury to their body.
Yeah, well, you see, we are this fanatic sport indoctrination.
Mhm.
I don't believe it's a good thing at all. Like,
Sports?
this being like fanatic about it,
Oh,
like
yeah.
doing excessive thing. If sport quit to be fun, that's the rule of thumb.
And I think Alyssa can relate to this, but a lot of times when you're in sports, if you get injured, you're kind of expected to walk it off.
I hope
Don't you feel that way?
I hope we overcame that thing. It was definitely like that, but I think there is in the last 20 years, our understanding is improving so much that we understand that this thing just toughen it up. We like, especially in football in the United States, that it used to be you just get back, but now there are some rules and regulation and so on. I think we are slowly starting to overcome that, don't we?
I would agree like immensely that at least our trainers and our coaches are more aware of the long-term consequences. However, that just warrants
Because
the
they're liable
athletes
if they
to be less vocal about what's going on. At one point, it was a,
Mhm.
hey, this hurts, and it's a, okay, rub some dirt in it. Now it's a, I'm not even going to say it hurts because I know what's going to happen if I do, which leads to almost, I would say, worse outcomes by not
Mhm.
being vocal about what's going on.
Yeah.
So
So it's a common thing when you're young. It's more common because of this sport injury, auto accident,
Mhm.
extraordinary event. But when you get older and older, they become naturally more common. So we had that the presentation that shows by the time you are 50 years old, only 35% of the people don't have spine problem. By the time you are 60 years old, almost only 5% of the people don't have spine problem. By the time you're 70 years old, almost everybody has a spine problem. 1 to 2% don't, and so on. So, and those 1 to 2% are those people who really worked the last 70 years
Mhm.
in that direction. So you see, that's a common thing. Now, so I come to you. I don't have any instability, no bladder bowel dysfunction, and no sign of instability with acute neurological deficit. So, and you do exam, but you do more than that. So, what's your workup? What do you do with me after you notice I don't have? You said you send me to physical therapy, but that's not the only thing you do. What else do you do?
No, there's many lists of conservative managements, and it depends
Mhm.
on if you know where it's coming from and what it can do. We do things diagnostic injections as well as therapeutic based
Mhm.
injections.
Injections, both diagnostic and therapeutic.
Yep.
They are not considered surgery, but they are they're like a more aggressive pain. We treat more aggressive pain for that. Not like if Amanda comes, oh, I have back pain, we are not going to send Amanda for right away for injection. Physical therapy, it's always a good thing. And by the way, physical therapy, I get a lots of patients. Oh, I have done it. I don't want it.
Mhm.
It doesn't work, and so on and so forth. What do you take on that? I mean, imagine. Let's play it. Oh, Dr. Alyssa, I have been doing it for so long. I hate physical therapy. They always take my money and they never help me. And I have done it every time I go there. They don't listen and so on. I don't want to do physical therapy. How do you convince me to get physical therapy?
That in itself is, it's less of me trying to convince you and sell you, more so trying to get you to physically buy into it. One of the things we do that most patients that do not want to try physical therapy or have tried it are ones that are also looking for surgery, or they're looking for more of the snap of the finger fix, respectfully, which then comes with the, hey, every surgery comes rehabilitation as well.
Mhm.
Meaning the best thing you can possibly do is try to gain as much strength stability in the spine as you can before we virtually remove some of that or create weakness after surgery.
And that's a very good take on that, is that we have to as well work with the patient, not against the patient.
Mhm.
So meaning that is one of the tricks as we use. Please, if you're my patient, don't watch this episode. That's one of the tricks we use, that we say they come here, they want to surgery. They have
Mhm.
done everything. They're tired of it. They just want to get over. There is something we have talked about in a sale technique. We call that ninja technique. Okay.
Okay.
And what's a ninja sale, Amanda? What can you tell us? You remember what ninja
It's-
sale is?
Yeah, it's just not being very direct. It's kind of being a little bit, I don't want to say sneaky, but going around the corner to get to the place that you're trying to be.
So literally, like, imagine you go to buy something in a shop, and the salesperson, they don't exist anymore, but they used to be. If you go to buy something, a salesperson would be there. They would sell you something, and they would get commission and so on. Imagine you go to buy a TV. This doesn't happen anymore. So if you're young, you may not know that. A person is just next to you, looking at the TVs as well, and then it sort of start a conversation. Hey, what do you think about this TV and so on, or this feature and so on? You don't know he's a salesperson. He's on your side.
Mhm.
But once he helps you, and that is a good thing, ninja technique is a good thing. Once he helps you to recognize what you need, he change the position to the other side and close the deal. That is sometimes what we do. Like when somebody comes and tell me I hate physical therapy, I don't ever contradict them. Yeah, they're expensive, they take time and so on. Oh, and they did this and it hurt me. Yeah, that sometimes can hurt you. But yeah, you should talk to them, tell them, and don't even hesitate to say, you know, maybe you need if they're truly upset with their physical therapist, do you want me to find another one for you? Be on patient's side. Convince them that they don't have to fight you, that you fight for them. But once you convince them that you're on their side, then you notice things become easier. Like I'm sure you guys know that often you send a patient to me that doesn't want to do that and so on, and I go in and out, and patient goes and does. Certainly, part of it is that I'm a doctor. Part of it is that when I go in and say, yeah, you need help, you need surgery, but guess what? The way I do the surgery, I don't filler your back. I keep all those muscles. Those muscles are going to be there. Now, in a regular surgery, I would totally agree with you. You do build muscle, and then I go strip them, fillet you open physically, literally. That's what we do in open traditional surgery. I destroy them, and they're all destroyed. So why spend time and money and effort to build? But not in my surgery. Stronger muscle help you to recover better after the surgery. So you convince them this is good for them. By the way, physical therapy is one of very few things we have level 1 evidence that it really helps people. So there are two reasons not to do that. Instability and instability.
Or not having a spine.
Or not having a spine. So that's the 3 reasons not to do physical therapy. Yeah, good one. I will adopt the third one. So you convince them it's good for them, and they need to go with that
Actually,
attitude.
I have a question. So
Yeah.
do you send them to physical therapy before getting imaging?
No, that's a parallel thing.
Okay.
Yeah, correct.
On the same appointment.
Almost always they are in congruency, or even sometimes if patients are wanting to avoid or radiation, for example, if I have younger patients, most specifically my younger women who are childbearing age, that you can tell based off a physical exam that there's no signs of immediate instability. There are times where we can directly go, hey, let's go do some exercises or see a physical therapist. If we don't get any benefit from that, hey, the next step might be moving towards the imaging. But I would agree most times that is done probably coinciding at
Sure.
the same time.
So how much physical therapy, Alyssa?
That's a great question. I'm a huge believer on you have to at least give it 4 to 6 weeks before you can give feedback on whether it is not going to be beneficial. However, I have seen immense amount of benefits from people who have to buy in for several months. You may have to spend the first month finding that balance before you can continue to then go to stamina and strength.
Now, standard is 12 visits, which is twice a week for 6 weeks, as you just said. And but that's give you the initial understanding. Is it going to help them or not? Anything below that, and that's how I convince my patient. I tell them, it's about building muscle around your spine to protect your spine. You don't go to gym and come back with 6-pack. You have to be consistent there. Oh, I go there and it hurts me and so on. Well, if it hurts you, please tell them. They go 6 years to school, sometimes even longer, to learn how, if what they do is painful, how to activate the same muscle in a different way. We call that modalities. When they go through their modalities, they write me a letter that they're not helping you, then we are good to go. And I never hesitate to blame the insurance companies. I always say, I'm so with you. But believe me, we can either do this and then go and smooth path, or we can go fight the insurance company for much, much longer. So don't ever hesitate to blame make them bad cop. If it gets you to your goal, meaning to do non-surgical treatment for the patient, that that can help them.
I would agree. You try not to throw anyone under the bus.
Oh, don't
but when,
no,
when it comes
it's-
to a patient looking at you saying, "Oh, you don't believe me, you don't trust me," that's never. Quite frankly, that's never the case. I mean, we trust you, we believe you. Oh, we believe that pain is real. We see it every
Oh,
day.
yeah.
Insurance companies, on the other hand, from firsthand experience, do not see it every single day
Well,
and
Well,
do not always trust you.
And the
So
physical therapy probably does hurt a little bit in the beginning. It's probably some movements
Yeah.
that they're not used to.
like I don't exercise. When I have to go stairs up, it's hard for me.
Yeah.
You have to.
Like, for example, my grandma, she's having a lot of back pain, hip pain. She refuses to do her physical therapy because it hurts.
may I ask how many days I was sore after my first yoga session? I'm still fairly young and I activated muscles that I have not in quite some time, and it was evident for several days following.
So I'm sure they're even telling the truth that it does hurt.
1,000%.
Mhm.
You know, the belief is there. Do not.
right?
No, we are not.
Underestimate
We are not questioning that, but
But it helps.
there's a level 1 evidence. It
Mhm.
helps, and we have to utilize it.
Yeah.
Or if you don't utilize it, insurance doesn't approve the surgery. So
Which is
Amen.
that's also true.
It is true.
Yeah.
We're not
Mhm.
lying
Right,
by that.
exactly. Yeah.
whatever, get the job done.
Mhm.
So 12 visits, and by then, after 12 visits, if patient is not getting better, you don't have to do more. It's not harm to do more,
Mhm.
except that physical therapist has got this degree from
YouTube.
from YouTube University or Google University, but they're trained to do the right
Mhm.
thing for the patient. Sometimes, if they're good, after 6 sessions, even they can say, but anything below 6 sessions, it is not really physical therapy. It is just showing your face there and coming back. So,
Plus, there's homework too, right? That they have to do.
well, at first, if they're physical therapists, they go a long way to school to really build up a project,
Yeah.
a sustainable thing for the patient. And first, they evaluate the patient about what the capacity is, and then start where it doesn't put the patient over the threshold that they are sore for 3 days. And that doesn't always work, obviously, we know,
Mhm.
but they're good at what they're doing.
Yeah.
Now, this is a little contentious, but what about chiropractic treatment?
I guess I should say, I have mixed emotions about chiropractic treatment. Going into school, I would be 1,000% all for it. And I'm not against chiropractic treatments. I'm a huge believer in whatever works. And when a patient comes and tells me that they get
Mhm.
benefit from going to the chiropractor, I'm all for it. It's when they come back and say, I have, say instability or degeneration, and they manually manipulate my spine in ways
Mhm.
that I do not agree with. So
in the traditional medicine, and I hear it a lot, and people know that, chiropractors know that, we have been extremely, almost, I would say, hostile to chiropractor.
Yeah.
And for 2 reasons. They are not us. And second reason is that we always see their bad results. Now,
very fair.
that the statistic is that 1/3 of the patient with the back problem, the first point of contact are chiropractor.
Mhm.
That's a lot of patient. And imagine everything that doesn't work or it goes the wrong way, they come to us.
Mhm.
So by this definition, we always see the bad result,
Mhm.
never their good result. The same way that one of my colleagues would say, boss, you have only bad result. Well, you saw 5 patients of my 5,000 patient.
Mhm.
Oh, let me tell you how many of your patient I saw. Same way with the chiropractor. So now, as a spine surgeon, I do not believe that when the spine is in a bad situation, that rapid motion are
Mhm.
really helpful to the patient, except few things that we know that there is a disease that the facets in the back joint, in the back of the spine, sometimes there is something that at least the theory is that the capsule get into the joint.
Okay.
So if before the inflammation start, you do the same motion rapidly, it releases the capsule, and then literally that can shown to be helpful. Now, Another thing that I think is going on with the chiropractor, you can say for them or against them and so on and so forth, is the insurance don't pay for that.
Hmm.
So meaning that, so number one, chiropractor do a lot more than just adjustment.
Correct.
Okay.
Correct.
Posture, massages, ultrasounds, releasing the spasm, reflex therapy, which is a huge, science for itself.
Mhm.
The most of the time when the patient get damaged and come to us, it's after adjustment and so on, and that's why we think that's all they do. Now, number one, number two, insurance don't pay for that. That put them at the disadvantage.
Mhm.
But I have learned to, as a provider, work with them rather than against them. We are, they want to help the patient, and they have a good, 1/3 of the patient with the back pain go to them. If there is something that we don't like them to do, we need to talk to them. Tell them that, if patient has spondylolisthesis, especially the mobile spondylolisthesis, don't do adjustment. If patient got a surgery before the bone grows back together
Mhm.
with a CT evidence, do not do adjustment
Mhm.
and so on, because we know that percentually they can, to a high degree, backfire. But I think the problem has been always that there is such a hostility. It is like you blame that, like uh, Mexican for all our ills, but you don't know a single Mexican, and you just think that everything is that's go wrong is because of immigrant, but you don't know a single immigrant. I have the feeling that MDs and the chiropractors are almost the same thing. Now,
Mhm.
something similar as well going on between, actually, that is getting a little off thing here of the path here, between the MDs and the DOs, doctor of osteopathic. No, we start accepting them more because we have more contact.
Mhm.
But in the real world, we have barely contact with chiropractors. So we covered physical therapy and chiropractor treatment. What else? What else do we do? What else do you do for the patient that come to you with a back pain?
Well, we discussed a little bit about injections just briefly. I mean,
We will get to that a
there's-
little more, but we do more. than
we
that,
do
no?
well. There's always kind of more to another one. I think
Bracing?
of that we didn't talk. Yeah, we didn't talk about bracing. We didn't
Go ahead,
talk about
talk about-
medication
Well,
kind of management
let's-
over the counters. So
Bracing.
bracing, yeah, that's something that we typically will try to order in the conservative management period, whether it's a scoliosis brace if someone's suffering from
Mhm.
some sort of spine abnormality, or if it's just a stabilization type brace, we use a lumbosacral orthotic typically, or an LSO.
Have you ever a brace?
Have
not
I?
necessarily spine, any brace.
Oh yeah.
Yeah, what kind of brace did you have?
Well, I've worn an LSO. I mean, that's how
Mhm.
I healed my back. I've avoided bracing most of my life, ankle braces through and through what I wore in high school.
Wrist,
Uh,
any?
I don't think I had to go the wrist route. I know I lived in ankle braces for a good chunk of my time.
What about you, Amanda? Any braces ever?
Mm,
Never?
mm-mm.
You never had braces?
No,
Jesus,
I've
yeah.
never really injured myself. Only concussions.
Yeah, you only injured others, huh?
She says only concussions.
Well, I'm
Only
not car,
concussions.
head brace.
So there's not a brain
Helmet.
brace. There's not a brain brace.
Right.
So what's your understanding what a brace does?
And it gives you some support.
Have you watched those movies that they are in wilderness, they break his bone and they take 2 pieces of wood and then they just wrap things around that to immobilize it? and
splint?
so on?
Yeah, I can
Like a
imagine it.
splint. Do they work? The splint and so on?
If they're done correctly, they work.
Yeah, they work. The problem with those wilderness splints is that you put a piece of wood, there's only contact in one area, and they're not really stable. And more or less, it immobilizes something. So, which is if you have a broken bone,
Mm-hmm.
obviously there is. So, let's go one step back.
Okay.
We have talked about that in the past. Pain. What is pain?
It's a signal of trouble.
It's the
Essentially.
noise of a smoke alarm. But if you have a broken bone, then pain is the noise of a smoke alarm to say there's fire, there's fire.
Mhm.
Okay, is not the fire itself. Pain is not the fire itself. So why does, when you have a broken leg, why does it pain you? Because something is broken, and more you move it, more the damage gets worse. So your body wants you to stop moving it.
Mhm.
Okay, so and the brace exactly does that. It stop motion and practically give that area. I'm talking about now a extremity brace, like broken bone
Mhm.
brace and so on. And then your small bones start healing and so on. When I was young, we did for ortho doctors, and they did a lot more bracing than now. We don't do that much bracing anymore. Like, I had a broken ankle. Actually, a motorcycle drove over my ankle, and then that's a good, interesting story. My father wasn't there. My uncles were there. They were just like, really not well-educated people. They did not take me to hospital with broken bone. They took me to a local, like a healing guy.
Mhm.
I have a lot of uncles, 9 of them used to, and 4 of them hold me down, and I was 10 years old. Yeah, and this guy pulled on my broken bone. If it wasn't broken before, it broke then. Then they wrapped my foot with the mashed potato. They did a potato mash, not a, didn't cook it, just shredded with eggs, and then they wrapped my foot with that, and then that the how no, it's actually slowly get better.
Okay.
Then so it took me literally, and then they put me in some homemade brace or something and so on. It took me literally 6 to 9 months before I could step on that foot again. By the time it
Wow.
happened, my Achilles tendon was shortened, my leg was atrophied, and this is where I'm going. Braces, they don't have only good side; they have bad side as well. For that reason, we don't do that often. If I had it today, they would have taken me to OR, reset it, put screws in.
Mhm.
I would have walked 2-3 days later, and I didn't have a shorter leg, a atrophied leg, and so on. But then would need to go to military service in Iran. I probably would have been killed in Iraq war. So that broken leg actually probably saved my life. But you see, this is not what we are going to talk about. We are going to talk about the brace.
Mhm.
Braces actually immobilize an area so it can heal. Now, and we are trying to uh, limit the use of brace because of inactivity causing atrophy.
Mhm.
Okay, but number one, in spine, there is no way you can externally make your spine inactive. There's so many segments, so many little joints, but we used to. I'm sure you have seen it, and Dr. Kim probably orders more than I. Those custom-made white
Hard.
turtle shell and so on and so forth. They are
Mhm.
they are the most effective way of immobilizing your spine. But then you are in my situation with a broken bone. By the time you are off the brace, muscles have atrophy, the joint have,
So can you say atrophy, like the definition for the layman's that are
Okay,
watching?
what is atrophy?
Loss of muscle mass.
Any kind of loss of tissue called atrophy.
Okay.
Any kind of atrophy.
Mhm.
And inactivity leads to atrophy. Like astronaut, they go to the space,
Mhm.
even though they have to go to a rigorous daily training and exercises, by the time they come back, they have lost 50 to 70% of their bone mass.
Mhm.
They have to be carried and so on. So inactivity leads to loss of any kind of tissue. Okay, so but in spine, it's really hard to do, and when you do those turtle shells, it's even worse. You lose function and so on. But for that reason, you have noticed I don't order those turtle shell anymore. What do we order? What do we do? What
For
kind of
the type of brace
vibration?
we use,
Yeah.
I guess I don't know. It's more of a hybrid brace, meaning it has an aspect of a hard shell. However, it's still what I would consider a soft-sided brace. So it provides that stability in the back while still providing a limited amount of movement of the core muscles.
Mhm. They are very highly engineered.
So,
Mhm.
like, let's say someone's having back pain. Should they go on Amazon and buy a brace?
And that is the point. You see, uh, sometimes when I have a wound on myself, I sew it myself. It's a bad idea, but at least I'm a doctor. I'm a surgeon. I know how to do that. Like, um, uh, this kind of, there are so many factors goes into that to considering what exactly, how so, and so on, and these are highly engineered.
Mhm.
Um, like I come back to, oh, Dr. Alyssa, I hate that brace. It doesn't let me bend. It doesn't let me twist. I cannot stand that brace. What does that mean? The brace is doing its job. They are highly engineered to reduce the activity that's damaging without stopping all activities. So, and if you can buy it on Amazon, it's probably not the one that we order.
No, probably not. Yeah.
Yeah, it's the same way that if you can't do that surgery in your kitchen, probably that's not the surgery that what we perform. It's a highly engineered thing that they reduce certain activity for certain situation, and then depending on the situation, sometimes we do LSO or TLSO.
Mhm.
We go from chest down, we go here down. Sometimes we put a chin part. Sometimes we put a part that push from the side. All those knowledges are available for everybody if you go to med school and then to residency and then come and do what we do. So don't try to do what we do, just complete bio. No, obviously, if it's a minor thing and if you're not really worried about it, to come and see us, yeah, help yourself, stretch yourself, do that first before you buy a brace. Though.
Stretching and then buy a brace.
Well, stretch yourself and then maybe just give it a rest a little if it doesn't get better. If you are worried about it,
Then you should go to the doctor.
then you should seek professional help. Not don't try to go to Dr. Google or Dr. Amazon. So we covered physical therapy, chiropractic treatment, bracing, and then these are proven way of helping patient. Chiropractor, I mean, I'm open for for a conversation. That should be part of our
Mhm.
conversation. Then you wanted to talk about injection and medication. Tell us a little about that.
Well, we utilize injections in clinic practice for a couple different ways. I mean, one of them I like to use more is from a medical side of thing would be diagnostically, meaning we are trying to attempt to find the core pain generator. Where is the pain coming from?
Pain generator, that's the term. That's an important term. Remember that, pain generator, because at the end of the day, you remember we said pain is a signal smoke of the
Yep.
smoke alarm.
Yep.
Smoke alarm is always local, meaning that it doesn't tell you that it's 3 building back there is in fire. It tells you where. Finding that smoke alarm, meaning tell you where that damage is. Where is that damage? Go ahead.
So typically we use that more from a lidocaine or a numbing agent when we use the injection. Meaning,
Exactly. The lidocaine or numbing agent is literally I can numb up your hand so you can go and pick up a hot iron. Okay, you still will burn your hand, but
Mhm.
you don't feel it. So, and that is the idea of lidocaine. Now, generally, we use something that longer acting than lidocaine, like
Right.
bupivacaine, or something that it gives patient longer. But that is something that I think we have to educate the patient about. That patient come to me, oh, that injection didn't help me at all, doctor. After 3 days, pain came back even worse. So explain that situation to us.
I hear that response quite often. They say, well, it worked for 24 hours. I felt like $1,000,000, and then the next day I woke up and it came right back.
And it came back even worse.
I get that often too. And
Yeah.
why? Well, when you start to feel pretty good, most of the time they say, like, I really thought you fixed me. So more than likely they were walking, doing a little more activity, doing things that they typically wouldn't just on a daily basis, meaning when they woke up the next day and the numbing agent
Sometimes
is
3
now
days
gone.
later.
Correct. They wake up and they think that something happened or that was not the fix, or whatever the medication inserted didn't do its job.
For that reason, usually we don't give only local anesthetic.
Correct.
We give as well steroid. Amanda, what are the steroids? What do you understand as somebody who's not in medical field? What steroids are?
Not really anything. I don't really know much.
Have you heard people take steroids?
Yeah,
What do they take it for?
getting stronger,
Build muscles.
building muscles.
Steroid is an anabolic. Almost every function in our body, in one way or another, is related to steroids. they build things, including heal things. Building and healing are very close. And they reduce inflammation.
Mhm.
They stop this damage that's going on. They reduce, they sort of imagine, there is a something bad is happening somewhere in our body. First, our police force, our military goes there, our immune system says, stop, I'm going to break the walls and do this and do that. And then, oh, bacterium, yum, 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 I'm going to eat you. And then release all my, literally release my digestive juices from my cell to kill all the other bacteria. By the way, you took hostage. Not only I'm going to kill the hostage taker, I'm going to kill everybody in that building at the same time. That's literally how
Yeah.
immune system works. Steroid comes and says, hey, guys, slow down. Just take a step back. Okay, they're gone. Stop. And then reduce that inflammation. It reduces the inflammation, and then it brings other cells in to start building it up. Like building that all the broken walls that our immune system just with the head went through it and destroyed everything and so on. Start building it up. Do you know how they really work? Steroids? Guess? What the cellular mechanism of steroid? How do they really work?
I'd rather you
They
explain.
go to the nucleus, and they activate certain segment of our genome that the gene expression then picks up. And there's a reason I'm saying that.
Mhm.
Gene expression picks up, and then new protein are being produced that repair and fix and think. Do you understand that how many steps I went? They have to go to the cell, then they go to the nucleus, then they connect to certain segment, some other protein or some other segment of the our DNA.
Mhm.
They express messenger RNA, transcription RNA, then build protein. Protein goes to the Golgi apparatus. Golgi apparatus goes to the vesicle, release them,
So,
and
and
so
that
on.
is all on a very cellular
It-
level that you just
lots
described,
of
like
steps.
1 millionth.
Yeah, but lots of steps.
Correct.
It doesn't happen right away. So how long does it take for the steroid to start really working?
Typically, I say give it about 3 days before you start
At
to
least
see a
5 days, I would say.
response.
Yeah, at
Yeah.
least 5 days, I would say.
Okay.
Now, the effect that you see in 3 days is very interesting. There is an effect at 3 days, but that's not the true
Okay.
effect of the steroid. The effect, imagine you're hungry,
Mm-hmm.
okay, and you're about to die and so on, and you say, okay, I'm going to give up. But then the person who's going to give you the stuff say, don't give up. I'm on my way. Good things are coming.
Mm-hmm.
Calls you on the cell phone. Just keep going. I'm coming. Steroids have this euphoric effect on your nervous system. So your nervous system says, good things are coming. They're not there yet. So you get the euphoric effect actually pretty fast.
Okay.
But then the actual effect, the food actually arrives in about 5 to 7 days.
Okay.
But you get the message, food is on the way. Your brain is start working, and we know that positive attitude always helps additionally, and that's what they do. But as well, they can have other effect. Like they're in a way, like, you told me that sometimes, people who get pot, they have opposite effect, that they became anxious, or they have sometimes it actually backfires. That effect on the brain, the people become anxious, and it just has
I get irritable a lot.
irritable
is what I hear.
steroid, yeah.
Yep.
But that is that effect comes sooner, but then the actual effect comes 5 to 7
Mhm.
days later, because it has to go through to all those steps. Okay, so then obviously we do as well the therapeutic injection,
Yep.
mostly related as well to steroid,
Yes.
reduce the inflammation. Then we have obviously many other medication, not non-steroidal pills.
Right.
Sometimes we give as well steroid as pills. What are they called?
Well, we typically do medral dose packs
What is
when we
that?
do that. It's where we do a larger tapered dose of steroids, meaning
Yeah.
we hit them with 6 pills in one day. Typically, we'll just say take them all in the morning, and then we taper down to 5, 4, 3, 2, 1.
And steroids are, you can in a short term, you give it whatever you want to give. And then, but if somebody has been on a long time on that, you have to slowly go up and
Mhm.
because it really mess up people.
Mhm.
In what
As-
way?
Well, if you have been on steroid for a long time and you quit that, you'll die you die before the thirst kills you. Let's say you have been on steroid for many years, and I stopped that, and I stopped giving you food and water as well.
So you'll
Before
die
thirst
before
kills
3
you,
days.
before thirst kills you, the literally
Like
withdrawal of the it's not a real withdrawal,
Mm.
but literally your body shuts down.
So it's not the same way that people die from alcohol withdrawals.
No, it's not. It's not that. Your body literally go to a hypotensive
Mhm.
crisis, meaning your blood pressure goes down, your body says goodbye, and your system, your organs, one after another, just close the
Wow.
door and you die. And that happens before, long before it happens in a day or so, or two.
Wow.
Yeah, if you don't have water, you can live 4 or 5 days. But if you are on steroid for a long time, that's why if I like one of the things we say, there are two medication. You look for it, you always continue. One of them is steroid. What is the other one that in the hospital that patient you always continue? Has a similar but different effect in a hormone that is produced.
Oh, thyroid
Mm.
or some sort of thyroid medication.
Yeah, thyroxine. So
Levothyroid.
T3
Yep,
or
okay.
T4,
Yep,
and so
good.
those you always continue. So we talked about Amanda. Where did Amanda go? It's vanished. Lack of
She got
steroids.
really bored of
Yeah,
us.
I think she ran out of steroids. So we did physical therapy,
Physical therapy.
chiropractic treatment,
Mhm.
injection, pain
Bracing.
management, bracing, and then other. But we give as well, like ibuprofen, which is non-steroidal.
Correct. I was
infla-
gonna talk some of
inflammatory.
that.
Go ahead.
Just in general, I always ask people, have you tried over-the-counter medications? And everyone scoffs, as I would expect. They're like, Tylenol doesn't do anything, ibuprofen, and I can understand.
They are
However,
with you for a reason. If that would have been enough, they usually don't come to see us. But yeah,
that's correct. However, there is a time and a place for these over-the-counter medications, specifically when it comes to steroids. If
Mhm.
someone's dealing with an inflammatory response, sometimes they're on, say, they got diabetes. Taking things such as steroids can mess up some blood sugar numbers, and it's not always easy. Whereas there is a possibility that taking scheduled ibuprofen
Mhm.
or Aleve, aspirins could give you some of that anti-inflammatory effect as well. However, there's kind of a stigma between having to take medications or the over-the-counter medications aren't going to work. However,
and there are non over-the-counter medication,
mhm,
and but there are certain routine medication that you always give. What are they?
like post-operative medications we use that
We
are
give it as well pre-op, muscle relaxer.
muscle
right?
relaxers. Yep.
What are they?
Typically, we go methocarbamol, or known as Roboxin, cyclobenzaprine, Flexeril,
Flexeril.
tizanidine, baclofens.
Amanda reappeared. Amanda is like a magician, She appears and
witch.
disappears. Or witch, yeah. I didn't want to say that.
Spooky
So-
season.
Have you ever had spasm, Amanda?
Sometimes, like, my eye maybe is
Or
twitching.
twitching.
Oh my God, you didn't have a muscle spasm like calf or
She doesn't
arm
have
and
braces.
so-
Well,
She's-
recently my finger was
Which one? The middle finger, like
yeah,
twitching.
well, it was during a meeting, but
Yeah.
my finger was twitching uncontrollably.
Okay, I'm not going to ask you. Have you had spasm?
I have, but I would consider
Can you
them
describe it?
self-inflict. Oh, it's when I call them Charlie horses and what have you. But what it feels like is your muscles just literally shrink together. They get tight. You can't relax them no matter how bad you try to
How
relax
painful is
it.
it?
Oh, they're painful.
Extremely
I would give
painful.
that 11 out of 10. Just there it goes.
Stretch that muscle. First thing you do that,
Oh, and
stretch
that
that
hurts
muscle.
too.
No, but that's the best thing you can do. And if you
Right.
don't do that, it gets worse.
Right.
Why does stretching helps spastic muscle?
I say I'm going to give the wrong physiological answer, but in my head, it's when you flex and in the tight, you do the opposite response.
To stretch it? No, well, your muscle comes together. One
Correct.
becomes like this muscle is this big. No, it's becoming this small because it's putting
You have to
Why
coax
does-
it back.
coax it back.
Talk nice to it.
Please be nice again.
Stretch out. So muscles are regulated in our bodies segmentally at the spinal segment. I mean, have you guys done like anatomy of the animal? Or
Oh, I'm
anything like
picturing
that
the
butterfly,
hooks and
inside of the spinal canal.
Don't
Yeah.
look at me.
No.
You already know I was not. I was
You
not
weren't paying
part of
attention.
that.
You were throwing balls to
No,
your
I was not
your
throwing
friends
balls.
in the
I was writing. I was the writer.
yeah you were
So I don't have
right.
to see.
Yeah. So, there are two things in our muscle that control how much it should contract or how it should contract, and that part is managed at the same segment that the nerves going our spine and back. One is so-called Golgi tendon apparatus. Do
Okay.
you remember from your school what that is?
Oh, I remember. The name comes very, very vividly.
It is literally a cell in your tendon.
Mhm.
That tendon, they don't stretch,
Correct.
right? It's
They're
a
not-
solid thing, but it feels how much pressure is on it
Mhm.
and report that pressure to spinal cord. That in itself inhibits the muscle. Say, muscle, you spent enough energy on this, quit.
Sure.
And it use actually some GABAergic and so on to reduce the amount of the muscle activities going there. The other one is muscle spindle, specialized
Mhm.
muscle fiber. That one shows how big
They
or small,
lengthen
how
and-
length of
Yep.
this now. So practically, when you muscle is getting really small,
Mhm.
you try to stretch it, you put a lot of sensory input on the Golgi tendon apparatus that goes and inhibits literally the
Muscle fibers
the,
from
the
continuing.
activation
Yep,
signal for the
yep.
muscle. Okay, so muscle relaxant are important, very important part of that, because when you are out of balance and lots of situation, the muscle spasm is a main part of your pain.
Right.
But then we give as well narcotic. We have to be extremely careful with that, but they're efficient, they're effective, they reduce the pain. Now, we are not going today talk about narcotic a lot, but there are as well, for especially when the pain become chronic, there are other medication. That one is the major medication that we give after the surgery, sometimes as well before the surgery, beside muscle relaxant and narcotic.
Hydroxyzine.
What is it?
Hydroxyzine is one of those medications that can be used, in my opinion, for kind of a wide variety of things.
Called it adjunctive therapy.
There you go.
Like
That's a
every
good
time I
word.
see Amanda, I want to take some hydroxyzine.
Jeez.
It's anti-anxiety medication. Yeah, right.
I don't feel bad.
For me taking hydroxyzine.
You're doing whatever.
So hydroxyzine is officially an anti-anxiety medication that works on our brain.
Mhm.
We don't give it necessarily for anxiety. Sometimes we do, but we give it because we know if you're overall reducing those anxiety-producing signals in your
Mhm.
brain, your body respond better at lower dose to other medication that try to help your
Mhm.
pain. Okay.
Mhm.
These are more or less what we discussed, the standard way of, you remember the title of the thing was standard and non-standard way of treating back pain or
Mhm.
spine problem. We sort of covered the standard way, things that we know they work, we have had lots of experience with, and there are tons of, and probably 100 times more non-standard way
sure.
of thing. Doesn't mean they don't work.
Say
It's just
traction. I've heard great things about
traction is part of physical therapy.
I would say
It
right.
can be. I'm not a big fan of traction for different
I say
reasons.
I'd love to go into that at some point too.
Yeah. Go into it.
Oh, I got patience to see
Yeah, I
yet
don't think
today.
we have time
Oh,
to cover none.
Okay.
But I
Okay.
say let's add it to the list because
Yeah.
there's some other questions. And
Oh, that is what you
Well,
mean.
some of
Okay.
them.
So, okay, we are 50 minutes into it. Then we are going to postpone the
let's do a
non-standard way
part 2 at some point.
for
Yeah.
part 2.
Totally.
Okay.
Thank you guys for watching. This was standard.
And non-standard.
No,
mostly
not
standard.
non-standard.
Ah,
ways of treating spinal pain and problems.
And
Okay.
love it.
tune back in for non-standard ways.
Ooh, that's going to be juicy.
I'm Amanda
I like
Armagoff.
it.
Yeah.
I'm Melissa Hopper.
And I'm Dr. Abbasi, who got stopped by these two.
Have
Sorry.
a good weekend.